Hello everyone, myself Dr. Harsha. Today we are going to deal with a topic called as differences in sex development. So we all know that during our post-graduation period, at least we come across, by the end of third year, we'll be coming across around 4 to 5 cases where we will be in a perplexed situation where we are not able to tell the parents what is the sex of the baby. So by the end of this class, we'll be able to approach a case of DSD. So DSD is nothing but differences in sex development. So when I was preparing for my NEET PG, there was nothing called as difference in sex development. They used to tell it as intersex, pseudohermaphrodites and genital ambiguity. When I was doing my post graduation, these terms were replaced by disorder of sex development. So now it has been replaced with differences in sex development. So just to be empathetic and telling that this atypical development of sex is not a disorder, they do just need a little extra medical attention. So on humanity basis, they have replaced this term as differences in sex development. Definition of this: it is a situation where genital appearance is ambiguous and assigning sex become difficult. It is nothing but it is a typical development of, first is genetic sex, gonadal sex and then anatomical sex. So first we should learn thoroughly how our reproductive system has been developed. So we all know that. Let's drive back to our basics. First we will learn the embryology. We have initially, during the formation of the fetus, we have two ducts. One is Wolffian duct, another is Mullerian duct. Wolffian ducts, wolf, men are wolf. This is how we can remember. So Wolffian duct, they form epididymis, vas deferens and seminal vesicles. Mullerian duct, which is also called as paramesonephric duct, it is going to form future, uterus, fallopian tube, cervix and upper 1/3 of the vagina. So what happens? Usually there is a dictum that we have a bipotential gonad. If nothing is there, by default or by nature itself, it is going to develop into a female fetus. So nature is female, India is female, the way we say Bharat Mata, so the nature itself is female. So in embryology also, if nothing is there, no interference is there, it is going to form a female baby. If there is a presence of SRY, which is called as sex determining region on Y chromosome. So we all know that females have XX chromosomes and males have XY chromosome. So SRY is an sex determining region on Y chromosome. If that is present, what is going to happen? If that is there, this is going to form a testis. So the testis, we all know that has two types of cells. One is Leydig cells and another is Sertoli cells. This Leydig cells is going to produce testosterone and dihydrotestosterone. Sertoli cells are going to produce Mullerian inhibiting factor. What is going to happen? So when there is an interference by SRY gene, there is a formation of testosterone, dihydrotestosterone and Mullerian inhibiting factor. This Mullerian inhibiting factor, what it is going to do is, it is going to regress this Mullerian duct. And what it does, the testosterone and all, they cause development of the Wolffian duct again, which is going to form this epididymis, vas deferens and seminal vesicles. Bipotential gonad. We have two ducts, that is Mullerian duct and Wolffian duct. The male hormone, that is SRY, if it is present, what it is going to produce? It is going to produce anti-Mullerian hormone and testosterone, and this is going to develop into a testis and seminal vesicles. If there is no male hormone, that is no SRY, it is the Mullerian duct is going to, again in future it is going to form uterus, cervix and upper part of the vagina. Bipotential gonad, we have Mullerian duct and Wolffian duct. So this is the picture where you have uterus and fallopian tube and cervix and upper part of the vagina. So this is regarding what? This is regarding internal genitalia. That is, so in a brief, this thing what I have explained is regarding how the internal genitalia are formed. So we have bipotential gonads, 2 ducts. Now we are going to deal with what? External genitalia. How the external genitalia is going to form. So usually in external genitalia also you have one tubercle, common tubercle. So what is going to happen? You have a genital tubercle here, as you are able to see in this picture. You have urogenital sinus, urogenital folds and labioscrotal swelling. So what is going to happen is, if there is a dihydrotestosterone, this common genital tubercle is going to differentiate into male. If there is no dihydrotestosterone, this genital tubercle will form female external genitalia, that is clitoris, labia minora and labia majora. This is regarding what we have learned. We have learned development of internal genitalia and external genitalia. So this is quick revision of the things which we have learned. We have a gonadal primordia. If there is no SRY, ovaries, so that gonad is going to convert it into ovaries, and ovaries, no anti-Mullerian hormone, the Mullerian duct is going to form fallopian tube, uterus and upper part of the vagina. SRY, for example, if SRY is there, so it is going to form testis, which is going to release Sertoli cells, and which has Sertoli cells and Leydig cells. These will produce different hormones, that is Mullerian inhibiting hormones and regression of the Mullerian duct. So Leydig cells, it is going to produce testosterone. This testosterone, what it does, it will strengthen or develop the Wolffian duct into epididymis, vas deferens and seminal vesicle. And this testosterone is also getting converted into dihydrotestosterone. This is ultimately going to form penis and scrotum, the male external genitalia. As previously I told, nothing is there, but by default it is female. So it is female, but it is nothing like that. We have so many genes which are responsible for the ovarian formation also, and we have genes responsible for testicular formation also. So these are few genes. So for testis formation we require SRY genes, SOX9, NR5A1, WT1, FGF9. For ovary we need WNT4, RSPO1 and beta-catenin, DAX1 and FOXL2. So these are the genes which are responsible for the formation of both ovaries and testis. This is typical. Genetic sex, gonads and anatomical sex. We all know that genetics is nothing but those chromosomes, XX and XY chromosomes. Gonads are nothing but ovaries. Then anatomical sex, internal genitalia and external genitalia. So anatomical sex, the internal genitalia, it is almost depend upon what? Anti-Mullerian hormone. External genitalia, it is almost dependent upon dihydrotestosterone. In the first trimester period, those labioscrotal folds are more susceptible for fusion, and this fetal testis, if it is formed, it has high affinity for human chorionic gonadotropin, which is produced by the placenta. So what happens in the second and third trimester? It doesn't depend upon HCG. The fetal hypothalamo-pituitary axis is going to become active, and these androgen, that is testosterone, dihydrotestosterone, are produced by luteinizing hormone. So then we have to evaluate a DSD. So there are certain situations where we need to just ignore the things. We cannot evaluate everything for DSD. So actually when we need to evaluate is when you have a penis and a bilaterally non-palpable testis. It is nothing but you have a penile thing, but you don't have testis in the scrotum. It is an empty scrotum. Then you have a unilateral cryptorchidism. Cryptorchidism means The one testis is in the scrotum, the other one we don't know whether it is in abdomen, inguinal canal, we don't know. But there is unilateral cryptorchidism along with hypospadiasis. What is hypospadiasis? Hypospadiasis is nothing but abnormal opening up of the urethral meatus. So in the penis it can open at the glans thing, at the mid shaft, or at the perineum, or at the beginning of the scrotum. So unilateral cryptorchidism with hypospadiasis. Or the third thing is when you have a severe penoscrotal, scrotal, perineal hypospadiasis, even if the testes are descended, even you have both the testes in the scrotum, but you have a severe hypospadiasis, that is perineal hypospadiasis, you need to evaluate for the DSD. So then when you have to evaluate is you feel that it is apparently a female appearance is there, but you feel that there is an enlarged clitoris and you are feeling some gonads in the inguinal canal, then also you have to evaluate. If there is a asymmetry in the size, pigmentation, or rugae of the labioscrotal fold, then also you need to evaluate. And if there is any discordance of external genitalia with the prenatal karyotyping. So if the baby is in the fetus, because for some or the other reason you have done a karyotyping, so it is showing XX, but when you do ultrasound you are finding the baby is having an male external genitalia. So there is a discordance of the external genitalia with the prenatal karyotyping. So these are the pictures. So you have an empty scrotum with a penile structure, and so for this you need to evaluate. For this one we can see here that there is a distal hypospadiasis, but the scrotums are full. In this diagram also, what is there? The urethral opening is in the middle of the penis, but the scrotums are full, so there is no need for evaluation. For this, here it is a penoscrotal opening and perineal opening, so don't evaluate for this two condition, you evaluate for this one. So in this next picture, what you are seeing? You are seeing one side the scrotum is full, and other side it is empty and you have a microphallus. So it is appearing as if it is a virilized female. So evaluate. So here also in this condition, we don't know whether in this picture, in this labioscrotal fold. So when we are looking at this picture, I am feeling it is a virilized female. I feel it could be a labia majora. We don't know. Or it could be a testis also with bifid scrotum with micro penis. So this also we need to evaluate, because here assigning sex is becoming difficult. So now we have learned the condition where all we have to evaluate. So unnecessary evaluation. See, now if you study DSD, if you go for a section or a labor call, if you see hypospadiasis, we'll jump and tell, oh, it is a DSD and we need to evaluate it. So the unnecessary evaluation is the male babies with isolated glandular or midshaft hypospadiasis. So in the scrotum both the testes are there, but you have a glandular hypospadiasis or a midshaft, so no need to evaluate. A male baby with unilateral inguinal testis. So a male baby is there, one side the scrotum is full, the other side the testes are in the inguinal canal. So don't evaluate. We can wait. The other testis may descend by the 1 month, 2 month, or we can wait till 1 year of age. Then a female baby is there. So what we are saying, there could be a labial edema or enlarged clitoris. So isolated thing, don't evaluate. If there is a preterm female baby with prominent clitoris, don't evaluate. Why? Because preterm baby, they have less fat. So we feel that as if there is a clitoromegaly. So don't jump and evaluate. So these are the certain conditions where we have to not evaluate. So clinical classification. So what are the clinical classifications? So we have already told you, it is genetic problem, gonadal problem, and we have chromosomal, gonadal and anatomical problem. So that is one classification. Now clinical classification. Clinical is problem in the sex chromosome. Another thing is 46XY DSD. So 46XY DSD is nothing but when you do a karyotype, the baby is XY, but there is some problem. There could be a problem in the internal genitalia or external genitalia, but The karyotyping is XY. So it is labeled it as XY DSD. Another thing is 46XX DSD. So slowly we will begin our journey with individual diseases. Starting with sex chromosome DSD, we all know that Turner syndrome we have 45X0. It is Turner syndrome. Klinefelter syndrome where we have 47XXY. There is something called as 45X bar 46XY, which is called as mixed gonadal dysgenesis. 46XX bar 46XY, which is called as ovotesticular DSD. So as we all, the in and out will be studying regarding Turner syndrome, Klinefelter syndrome. So I will not be going in detail, but we will discuss the mixed gonadal dysgenesis. So we all know the features of Turner syndrome and Klinefelter syndrome. So what is mixed gonadal dysgenesis? This disorder is most often due to 45X bar 46XY mosaic karyotype. So what is happening here is a fetus is formed. There is problem in the cell division. So in PUC, when we are in second PUC or when we are in our 10th standard, we used to learn regarding cell division, what is called as mitosis and meiosis. So when the embryo is formed, there is a cell division. So during cell division, there is some problem in the mitosis and meiosis that is causing this mixed gonadal dysgenesis. So some part of the body they are carrying with 45X and other part of the body or some part blood or in this thing they are carrying 46XY. So the hallmark of mixed gonadal dysgenesis is presence of testis. For example, 46XY is there. A presence of testis which may be normal or dysgenetic on one side of the body, and the other side it could be a dysgenetic or probably a streak gonad. Why? Because there is 45X. We don't have this Y factor. There is only 46XY. So the physical findings are 90% of the infants diagnosed with prenatally, they have a typical male genital appearance at birth, and each gonad gowns the differentiation of the ipsilateral internal genital structure. So in this figure you are seeing what? There is a dysgenetic gonad because you have 45X. So you have a dysgenetic gonad. Here in this you have 46XY. So you are seeing a testis, proper testis here. Here, because there is a streak gonad, there is no production of anti-Mullerian hormone this side. So this is Mullerian duct. The Mullerian duct this side it is persisting. Here you have a proper testis here and the Wolffian duct, and there is a regression of the Mullerian duct. The internal genitalia is governed by the presence of local hormone. Because the testis is there, you have anti-Mullerian hormone. Here you have a dysgenetic gonad that is not able to produce anti-Mullerian hormone. That's why there is a persistence of this Mullerian structure. So it depends upon the availability of the local hormone. Next we'll discuss regarding what? Ovotesticular DSD. So what I told, in mixed gonadal dysgenesis, there is a single fetus because there is a problem in the cell division. That's why there is 45X and 46XY. Here also there is a problem. What problem? The single ovotesticular DSD, most of the time it has both 46XX and 46XY. How? Because here the problem is usually there are two fertilized egg. There is something called as chimerism. They both join, they form a single fetus. We have all learned regarding chimerism. Lion face, goat body. Because of this chimerism, you have what? You have two cell lines. So most of the time, we don't know the local thing. You may have 46XY. The skin, when you do a karyotyping from the skin cells, you might have 46XX. It depends. So most of the time 70% are 46XX, less than 10% are 46XY. Remaining would be mosaicism. That is very lesser percentage. It is mainly due to what? Chimerism. Two eggs, this thing, they combine and form a single embryo. So the physical finding is same. The external genitalia may have a typical male or a female appearance or may show ambiguous genitalia. So the internal structure depends upon the presence of local hormones. So how do you diagnose this ovotesticular DSD? You do a laparoscopy, do a gonadal biopsy. You will find what? The ovotestis. Sometimes the girls with intact ovotestis, they experience virilization of the external genitalia. The boys may undergo breast development. So now we have finished with sex chromosome DSD. Now we are moving to another step, that is XY DSD. So the classification of XY DSD. XY DSD is nothing but already karyotyping is done. It is showing XY, but there is some problem. So what problem? So first we will classify. So what are the problems? So the major categories are 46 XY is there, but the problem in the gonad. There is a problem in the gonadal system. There is complete gonadal dysgenesis, partial or gonadal regression or ovotesticular DSD, or the gonads are formed but they are not able to produce sufficient amount of hormones to act, or hormone is also adequate but there is a receptor level problem. So gonads may be problematic, but there could be what? Problem in the synthesis of hormone also. So it depending upon, that is defect in androgen biosynthesis, defect in androgen action and receptor level defect. So what are the causes, genetic causes of XYDSD? So I have already mentioned, for the testis to develop, you require so many genes, NR5A1, SRY, DAX1, SOX9. So if there is a problem in all these genes, again it will lead to 46 XYDSD, that is XYDSD. So the WT1 gene, the classical feature is along with the DSD, it will have renal involvement along with renal failure. Why renal failure? Because this WT1 gene is also involved in the development of your kidneys. So this gene is shared by both of them. Then for example, SOX9, that is SOX9, this gene is there, the defect in this gene. So you will have for XYDSD also and skeletal problem also. Why? Because the SOX9 is also responsible for the development of the bones, which is going to develop into skeletal dysplasia. DAX1, same again XYDSD, because this gene is shared with the pituitary and adrenal involvement, you will have pituitary and adrenal involvement. So let's start with a single disease. So I told there is XY, but problem in gonad formation. There is problem in hormone synthesis. So gonad problem, the gonad, bipotential gonad, what is required? SRY is required. So there is an abnormal functioning of the SRY that is going to produce complete gonadal dysgenesis. What you are expecting? If SRY is not functioning properly, there is no formation of what? Testis. If there is no testis and no hormones, the most of the time the fetus will be like a female baby. But when you do a karyotype, you are finding it as 46XY. So because the testis is not formed here, because the SRY is not functioning properly, so you don't have what? Dihydrotestosterone, you don't have testosterone. So it is like a inner side also, there is no Mullerian regression. So what you are expecting? The baby will be having what? Uterus inside. External genitalia is also what? It is like female. But when you do a karyotyping, you will have XY. So sometimes if the complete gonadal dysgenesis is there, the gonads are there. They are very streak like gonads sometimes. So there are more chance of what? There are more chance of going into carcinoma also. So what happens in partial gonadal dysgenesis? The incomplete testicular differentiation is there. So incomplete or lesser amount of Mullerian inhibiting factor. So again varying degree of external virilization and Mullerian regression. So next is what? Ovotesticular DSD. So oviotesticular DSD I have already told, 46XX is also there, 46XY is also there. Depending upon whose concentration is more, that is going to have the impact on internal and external genitia. For example, in this figure, there is an incomplete Wolffian development because of what? Insufficient androgen. So the testis is not developed properly, it is not producing the hormones. There is an insufficient or incomplete development of the Wolffian duct. Here, because of this, here in this side there is an insufficient anti-Mullerian hormone, so there is no regression of the Mullerian duct. So this side you have what? Mullerian duct features, this side you have an incomplete Wolffian duct, and in genital you have a ambiguity. So that's why it is called as ovotesticular DSD. So the crux of the story is, if we want to learn DSD in a very good manner, we have to be perfect in the embryological development of the testis and ovary and internal and external genitalia. So if we want to approach, we want to know which kind of DSD it is, where is the problem. So we will spend some 5 to 10 minutes of time in this flow chart, because this is very important. If we know this chart, we will be able to evaluate the cases. So what is this? So we have already learned this pathway. This is a steroid synthesis pathway. What are steroids? You have mineralocorticoid, you have glucocorticoid, and we have sex hormones. So we used to, when I used to go for a coaching, our sir used to tell, the inner we go, it becomes sweeter. Salt, sugars and sex hormones. So let's come to the main pathway. So we all know that we have 7-dehydrocholesterol. So this requires DHCR7 gene. This is going to convert it into cholesterol. Cholesterol is getting converted into pregnenolone. Pregnenolone so is getting converted into progesterone. Progesterone, this vertical pathway is going to give your salt, that is mineralocorticoids. This horizontal pathway, so if you concentrate on this side of the flow chart, it is going to give you most of the androgen and estrogen. So in this pathway you have what? Sugars, that is cortisol. So there are so many enzymes, already we have read it for our entrance, right? So we have already read it for our entrance. So we'll just have a look. So just remember, this side of my right hand side pathway is mainly responsible for what? XY DSD. And my left hand side of the pathway enzymes, the vertical path, I am not talking about this thing. Right now I am talking about the vertical pathway. If there is an enzyme problem in the left side, that is vertical pathway, it is purely what? It is purely what? It is XXDSD. Here, this side it is purely XYDSD. Why? Because if there is no production of testosterone, androstenedione, dihydrotestosterone, for example, if this is a male child, this side it is a male child, what is happening? For example, we have deficiency in, suppose, 3 beta. Let's say 3 beta problem. This is a male child. What is going to happen? Because there is a problem in the 3 beta, there is no formation of androstenedione, testosterone and dihydrotestosterone. So if it is a male, what is going to happen? It would be a what? Under-virilized male. So the proper external genitalia or internal things will not be formed. It would be a what? Under-virilized male. So under-virilized male, or it could be a female also, we don't know. So this pathway is mainly for XYDSDs. So if there is a problem in, so what is going to happen? If we think about 3 beta hydroxysteroid dehydrogenase deficiency, if this pathway is blocked, This is also here. This 3 beta is also here. So what is going to happen? It is a salt wasting kind of situation. There is no production of aldosterone, there is no production of cortisol, there is no production of sex hormone. It would be a XYDSD with salt losing condition. For example, if we talk about this 17 beta thing, what is going to happen? So we'll discuss regarding 17 beta. For example, if there is a deficiency in 17 beta hormone, so there is no production of testosterone. What is going to happen? If there is no production of testosterone, everything, so there is a blockage here. There is a blockage here. Because there is a blockage here, everything will come, all the end product will come and get stuck here. So what is going to happen? The chain will shift towards this side. So more and more salt is produced, that will lead to hypertension. So this would lead to hypertension. Suppose if there is a defect in 17 alpha hydroxylase, what you are going to expect? Suppose there is a deficiency of 17 alpha hydroxylase, what you are going to expect? There is, for example, here there is a male baby. There are no androgens produced here. So undervirilized male baby, or it could be a phenotypically, matlab external genitalia could be of a female also. Then along with that, because there is a defect in this pathway, there is a more and more production of what? Aldosterone. So because there is a pathway, here the pathway is blocked, there is hypoglycemia also. So it could be what? Undervirilized male with hypoglycemia and with hypertension. Why? Because, for example, the water is flowing like this in this direction, and the water is also flowing in this direction. So if you keep a blockage here, if you put some blockage here, what the water will do? It will move towards this side. More and more it will move towards this side. So just imagine you are putting a blockage to the water flow in this direction. The water will flow more and more towards this direction. So I hope I am clear. If there is a deficiency of 17 alpha hydroxylase, you will have low cortisol, undervirilized male, or it could be a phenotypically female, and you will have a hypertension. So same with the 1720 lase. So if there is this is defective, or the enzyme is less, again there is more and more of salt production, and there would be no hypoglycemia, but there would be no hypoglycemia, but there would be undervirilized what? Undervirilized male, or a phenotypically female. So this is regarding C. Whenever you think of a XY DSDs, please do remember this pathway and this pathway. So what are the hormones here? So when you go up also, so this will start from cytochrome P450, 3 beta, 17 alpha hydroxylase, 1720 lase, and 17 beta, then 5 alpha reductase. So this is regarding what? XY DSDs. Suppose. So now I hope I am clear in this. If there is a female baby, female means genotypically or genetically it is XX, female baby, the baby is having 21, that is what? 21 alpha hydroxylase enzyme deficiency, which is most common. So what will happen? Because there is a blockage in this pathway. What is the water is blocked. The water is coming here, you have put a blockade here. So what the water will do? It will rush from here. So what is going to happen if it is a XX female, 21 hydroxylase deficiency, no aldosterone, no salt, no sugar, but it is going to produce excess male hormones. So if it is a female baby, it is going to virilize. So it is what? Congenital adrenal hyperplasia. So it is what? Virilized female. Now we have dealt with what? 21 alpha hydroxylase. So it is salt losing. Why salt losing? Because why it is salt losing? Because when there is a blockade here, there is no production of aldosterone, cortisol. So salt losing, then the flow is towards this side, more and more androgen. So next we will deal with 11 beta hydroxylase. So if there is a problem in this enzyme, what is going to happen? Again this pathway is getting blocked. So if there is a 11 alpha hydroxylase problem, what is going to happen? For example, again if it is a female baby, same, it is a virilized female, because again the hormones are like going this way. If it is a female, again it is going to get virilized, but there will be no shock here in 11 alpha hydroxylase. Why? Because this deoxycortisone, already during entrance preparation we have learned deoxycortisone will act as a cortisone, so you won't have this one hypotension, rather you would have a hypertension. For example, if you have a, so in this only, if the 11 alpha hydroxylase deficiency is there, if it is a, suppose if it is a male baby, what is going to happen? So the block is here, more and more testosterone is getting produced, dihydrotestosterone is there. So if he is a male, we are expecting what? Precocious puberty. Precocious puberty. So along with precocious puberty, we will have what? We will have hypertension, because deoxycortisone is going to act like what? Cortisone. So this is the final pathway. I hope I am clear. This side it is, most of the enzymes is what? From this to this side it is XY DSD. Here it is XX DSDs. So I have told 17 beta hydroxysteroid dehydrogenase. So what is going to happen? So already we know the karyotype is XY. So XY DSD. So then 100% there would be a, because if there is Y, there will be a testis in this case, because we are dealing with defect in androgen synthesis, not gonadal dysgenesis. So there is a problem in hormone synthesis. There are already gonads. So testis is there. So what will happen if there is 17 this thing we have already discussed. It could be the genital ambiguity could be atypical, 3 beta atypical. This liase also I have described. It could be a female, because there is no testosterone, no dihydrotestosterone. The STAR, that is steroidogenic acute regulatory protein, that is the first enzyme. If that is there, there is a salt losing, nothing is going to produce. This is regarding what? Just it is about what all the things are there. So what if the enzyme is deficient, what is going to happen? STAR deficiency, salt losing. 3 beta, salt losing. 17 hydroxylase enzyme deficiency, you will have hypertension. If that the first enzyme DHC, you will have syndactylyl and salt losing and low cholesterol. So defect in testosterone. So now we have what? We have learned defect in all those enzymes, and there is something called as defect in testosterone metabolism. So the testosterone has to get converted into dihydrotestosterone with 5-alpha reductase enzyme. Because there is a deficiency of that enzyme, what will happen? There is no production of dihydrotestosterone. Most of the external genitalia could be what? Female, because there is no dihydrotestosterone. Then there is something called as end organ resistance. End organ resistance is you have testosterone as well as dihydrotestosterone, but still what is happening? There is a problem at the receptor level. So that is because the hormone is not acting at the receptor level. There is more dihydrotestosterone and testosterone, which is called as what? Partial androgen insensitivity syndrome or a complete androgen insensitivity syndrome. What is going to happen in complete androgen insensitivity syndrome? More and more testosterone and dihydrotestosterone is there. What is happening? Because more testosterone is there, peripherally it is going to convert into estrogen through the help of enzyme aromatase. So the estrogen will be more. So what is going to happen? When you do a karyotyping of this person, it will be XY. When you do a USG, you won't find what? You won't find any internal genitalia structures like female uterus and all. But you may find what? Some gonads. It could be abdominal gonad or inguinal gonad. The external genitalia will be female. So because of excess estrogen, their breast development, the overall look will be what? More and more female. But when you do a karyotype, it would be what? XY. So sometimes average would be best rather than more beautiful. So the other factors are maternal drug ingestion. So mother is taking spironolactone, which is an anti-androgen. Mother is taking finasteride, which is an 5-alpha reductase inhibitor. Phenytoin exposure. This is all going to cause XY DSD. How to evaluate? Look for a presence of testis. So if the testis is not palpable, do a USG or MRI. Do a anti-Mullerian hormone level and a laparoscopy. So what are the lab tests you need to already have explained every hormone individually. Do a serum electrolytes, AMH, cortisol, testosterone, dihydrotestosterone, androstenedione, 17-hydroxyprogesterone. There is something called as mini puberty. You have mini puberty is nothing but immediately after the birth, all the hormones are in the higher level. After 6 months, they will fall to a pre-pubertic level. So do a HCG stimulation test, given 2000 IU of HCG IM route, and then measure your androstenedione, testosterone and dihydrotestosterone. Just measure these hormonal level before the first dose and 72 hours of giving HCG. So this is the approach. I have already explained everything in this. It is just a flow chart. So this also I have explained. It is what? Same. These are what? These are prime enzymes. The star enzyme, CYP15, these are all 3-beta. These are all the first enzymes. This peroximo oxidoreductase enzyme P450, these are all this one. First enzymes. Because there is a defect in the first enzyme, you will have less androstenedione, testosterone and dihydrotestosterone. 17-beta is what? It is going to convert androstenedione into testosterone. So if there is a deficiency of this, you will have more androstenedione, less testosterone and dihydrotestosterone. What is 5-alpha reductase enzyme? It is going to convert testosterone into dihydrotestosterone. If there is deficiency here, these both will be raised, this amount will be less. What happens in AIS, androgen insensitivity syndrome? Everything is in excess, there is a defect at the receptor level. So this is all what? Ratio. There are some ratio when to call it as AIS, when to call it as there is a defect in the 5-alpha reductase. It is just a ratio. So this is the approach. So this is a final chart for XY DSD. Go look for a palpable gonad. Just check, just go and see whether the gonads are in the inguinal canal or they are in the abdomen or in the inguinal ring. If you find the palpable gonad, if it is present, look for the Mullerian structure. If Mullerian structure is present, you have a palpable gonad also and you have a Mullerian structure also, it is nothing but there is a what? Anti-Mullerian hormone deficiency, or there could be a problem. The hormone is also there but the receptor level problem. If you see a palpable gonad along with Mullerian structure absent, go for the testosterone level. So if you find testosterone is low, see whether it is a salt wasting. If it is salt wasting, I have already go through a enzymatic pathway. If it is salt wasting, the most probable problem is 3-beta, P450 enzyme and star defect. If there is no salt wasting, there could be what? Problem in this. That is 17-beta hydroxysteroid dehydrogenase. That is, there is a problem in what? Conversion of androstenedione to testosterone. So if the testosterone level is high, look for dihydrotestosterone. If dihydrotestosterone is low, obviously there could be an enzyme problem. If that is also high, it is 100% androgen insensitivity syndrome. Then look for palpable gonad. If the palpable gonads are absent and Mullerian structures are present, it could be what? Gonadal dysgenesis. Now we will move quickly to what? 46XS DSD. So 46XS DSD, so it is also same. There is a problem in the gonads, that is bipotential gonad which is going to form ovary. There is a ovotesticular DSD, then gonadal dysgenesis and testicular DSD. There could be androgen excess because female baby is there, androgen is high, or other causes. Even though it is a XX, when you do a karyotype, it is XX, but there is a what? Translocation of SRY gene insertion. That is, the SRY gene is inserted into the X chromosome, which is causing the maleness. So most of the time they are phenotypically male. They are ambiguous, 20% ambiguous. Men have a normal sexual development and puberty with small testes and azoospermia. Why this condition? One condition is due to SRY insertion into the XX, and another thing is SOX3 and SOX9 overexpression, which causes more maleness. So causes for androgen excess, I have already discussed. It is androgen excess is due to blockade. I had told water is flowing both the side. There is a blockade at one side, the water will flow in the opposite direction. So more and more androsterone, testosterone in 21 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency and 3 beta this one. So androgen excess. So this is all. Salt wasting, 21 salt wasting we have already discussed. 3 beta salt wasting. 11 hydroxylase I have already told, hypertension because why? Because there is high level of deoxycortisone which is acting like and cortisone, that is like a salt only. Then aromatase problem. Cytochrome P450 enzyme. So this why this is required is, this enzyme is required for functioning of, and matlab this enzyme is required for functioning of all these genes, 21 alpha, 17 alpha, 1720 lase and aromatase. So diagnosis, how you will diagnose CAH? Most of the time it is usually the CAH they present with what? Shock. A virilized female they present with shock usually from 5 days to 14 days of life. There is no hard and fast rule. They can also present as late as 1 month of age. 1 to 2 episodes of vomiting or 1 to 2 episodes of loose stools might also cause shock in the baby. So please do evaluate 21 alpha hydroxylase deficiency, which is most common, that is 1 in 16,000 incidents. So you have to measure what? 17 hydroxy progesterone level. So how you will measure? It is usually measured between 48 to 72 hours, because if you sample before 48 hours there are high chance of having a false positive result. You will have false positive result in prematurity, low birth weight and ill infant. There could be false negative report also if there is an antenatal steroid admission history. How you will treat a CAH when it is in shock? Give hydrocortisone 20 mg per meter square per day TID. It is a maintenance dose, but if the child is in shock you have to give a stress dose, that is 25 mg bolus followed by 50 to 100 mg per meter square per day until the baby is stabilized. Start with fludrocortisone, that is mineralocorticoid 0.1 to 0.2 mg per day. After stabilizing, start with salt, normal salt, that is 1 to 2 gram of salt along with breast milk TID. There is something called as fetoplacental aromatase deficiency. Aromatase is the one thing which converts dihydroepiandrosterone into, it will protect the dihydroepiandrosterone from virilizing effect on the mother and the fetus. Usually it will protect female fetus and the pregnant mother from androgenic effect. There are certain conditions, that is maternal hyperandrogenic condition, like mother is having CAH, mother is having ovarian tumor and adrenal tumor, and mother has taken some medication during the first trimester. So evaluation of a case of DST. So what history you are going to take? So ask for any maternal drug exposure, maternal virilization, placental insufficiency, or there is a prenatal finding of ambiguity. So before only, like in the intrauterine period only, they have, because if they have a previous history of a CAH baby, you you can go for a karyotyping to know whether it is male or a female. So if there is a karyotype discordant with the phenotypic sex, when you do a ultrasound, then you suspect this one DSD, XX DSD. Okay. So there could be some other problems also associated with the DSD, because there are few genes which are sharing both genetic also and some other organ development also. So you could have oligohydramnias, renal problem, skeletal problem. So family history asked for a miscarriage, sudden death due to vomiting, that is more in favor of CAH. Asked for a pubertal delay or a precocious puberty or infertility or a corrective genital surgery or an unexplained death, suspect DSTs. In clinical examination, what you want to see? First, exclude the normal variant. Apparent clitoromegaly due to reduced suprapubic fat, leave it. Buried penis because of fat, which is it is feeling as if there is a micro penis. So you have to take a stretched penile length. Isolated penile hypospadias, especially mid shaft, glandular, leave it. If there is a labial adhesion, leave. So don't evaluate. So what you have to assess? In general, you have to assess the presence and location of gonads, degree of labioscrotal fusion, genital symmetry, the number of urogenital opening, and is there any palpable gonad in the inguinal canal. So what it suggests, so when you do a karyotyping, or most of the time what is happening, when you do ultrasound, if you find a Mullerian structure, USG, the basic USG will do, you are finding uterus, but there are no gonads. So what it is indicating? It is indicating androgen excess, that is 46XX DSD. So now in the second scenario, you have a palpable gonad. So you have palpated the gonads and you have done a USG, there are no Mullerian structure. It is what? Androgen deficiency, undervirilized male, that is 46XY. So you have palpable gonad also. When you do a ultrasound, you are finding Mullerian structure also. It is nothing but gonadal dysgenesis. If there is no Mullerian structure at all, when you do a USG, there is no palpable gonad, or sometimes the gonads could be in the abdomen like testis. It could be a testicular regression syndrome. So what is this? This is just I have put, this is called as Prader staging. It is developed to look for a virilizing female in case of congenital adrenal hyperplasia. There is some scoring system for CH. This is what? This is for a XY-DSD. This is called as external masculization score, EMS score for XY-DSD. It is nothing but what they are giving, some score. If the baby is normal, the score is on the higher side, 3. If it is less, it is 0. See, for example, just one example I will give. Here you have what? Here you have what? You have a micro penis. So it is 0. Here you have a normal penis. Here normal, they have given 3. So here in this you have a labio-scrotal fusion, like in labio it is like looking like a bifid thing. It is not looking normal. So they have given 0. For this they have given 3. For this one, for glandular, the distal urethral meatal opening, they have given 3. But for perineal they have given score 0. So this is just a score to look for external masculinization in a male, that is XY-DSD. So we'll go next. Micropenis is nothing but what? Stretched penile length less than 2.5 cm in a term newborn. Clitoromegaly is more than 1 cm. It is abnormal. There is something, so I just told some scores. There is something called as anogenital score also. Anogenital score, what they'll do is they'll measure some distance from anus to vaginal opening, like that. So if there is a virilized female, the anogenital ratio would be more than 0.5. So imaging. Now next what you want to do? The simple what we have in first hand is pelvic ultrasonography to detect uterus, to detect Mullerian structure, identify gonad. Are there any associated renal abnormalities? Because WT1 defect, which is responsible for the formation of testis, is required for the development of kidney also. So there are high chance of renal abnormality. So identify gonads, identify renal abnormalities, and if you don't find gonad, go for a MRI pelvis, or still if you don't find gonads, you can go for a laparotomy also. You can go for a widening cystourethrogram to demonstrate vagina, cervix and utricle, and also if there are any abnormal urinary genital communication, and it would be helpful for what? Pre-operative planning also. So management, how you will manage a case of DSD? First, treat life-threatening condition, educate and support parents, decide the gender of rearing after a thorough complete evaluation. Just don't rush and say after doing few investigation that it is a male or a female. Initiate disorder specific therapy. It is usually multidisciplinary approach where we require a surgeon, we require a psychologist, where we require endocrinologist, pediatric endocrinologist, genetist. So just why psychologist? For example, in androgen insensitivity syndrome, where there is what? Defect in the peripheral receptor level. The testosterone is also high, dihydrotestosterone also high. Because these are high, they are not acting peripherally, there is a problem at the receptor level. What is happening? The testosterone is getting converted into estrogen sometimes. But because of high testosterone in the intrauterine period, what is happening? It is affecting the brain. So they feel more like what? Male, but external genitalia is of a female. So it affects the brain development also, the sexual behavior, the gender identity, everything is depend upon those things. So psychology is must. So immediate management, serum electrolytes, blood glucose level, promptly recognize salt wasting CAH, start steroid replacement therapy, stabilize before definitive evaluation. Parental counseling, it is empathetic counseling. You all know why the empathetic counseling is required. Explain the parents the diagnosis, the etiology and the sexual development, and discuss also regarding the fertility outcome, the treatment option. Just don't prematurely label them as he or she. Specific medical management, in CAH we replace with glucocorticoids, mineralocorticoids. For example, testosterone is less, it is not forming, we will replace with testosterone. If there is a 5-alpha reductase deficiency, the topical application of dihydrotestosterone would help. If there is a complete androgen insensitivity syndrome, the gonads are present, so remove the gonads and give a estrogen replacement therapy. Gender of rearing, assign only after complete evaluation, consider the fertility potential. Usually what happens, if it is a 46XX DSD, we do advise for a female rearing. But if it is 46XY, usually we advise for a male rearing except for complete AIS. Why? Because already external genitalia is more of female. So it is very difficult for a male rearing. Surgical management, go for a clitoroplasty if there is a clitoromegaly. Vaginoplasty until after puberty. Why vaginoplasty? Because if you do vaginoplasty when the baby is very small, in the pediatric age group, there are high likely chances of vaginal stenosis. So you have to do a recurrent dilatation. So go for a vaginoplasty after puberty. Correct hypospadiasis. If there is a risk for gonadal tumors, do a gonadectomy. And complete AIS has a low risk and biopsy after tumor may survive. So AIS I have already discussed. So thank you everyone for the patient listening. I know it is a very complicated topic. Rather than complicated, we have some there is a hindrance in learning this topic also. So do actually, there is a link, the PPT can be downloaded from the below provided link. Please do download and read.